Good morning and happy Friday. Today we are joined by a team of 4 fabulous folks to discuss teaching specialist level goals of care conversations to new palliative care specialists, whether that be a new team member or a fellow. I'll introduce them in the order of the number of goals of care conversations they have under their belt. First, we have Alicia St. Peter. She's the newest member to our St. Luke's team, fresh out of orientation and here to offer that perspective. Next, we have Dr. Andrei Chernisov, a recent graduate of our HPM fellowship and only 16 days out from there. We have Dorothea Wilson. While newer to the field of palliative care, she has quite a bit of experience from earlier in her career. And last but not least, Patrice Fidel. Patrice is our lead palliative NP at Advocate Aurora. She's been a nurse for over 20 years and a palliative care specialist for over 8. The format for today will be a presentation with a variety of viewpoints, and then we will open it up for discussion. So Patrice, I will hand the mic over to you.
Great, thank you, Marty. So like Marty said, my name is Patrice. I'm the lead APC. I'm a clinical nurse specialist by background. And I've been with the program for 4 years and a palliative care specialist for 8. And I know that within our team, we have a lot of learners coming through, whether they be fellows, new APCs, nurse practitioner students, residents, what have you. And so it kind of got me thinking on how do we go about teaching the goals of care discussion? Because there's a lot of different skill sets that we teach as palliative care specialists. But for me, when I was learning this, and to some extent when I'm teaching it, this seems like the big skill set, the one that probably brings on the most anxiety sometimes, because it's a very complex skill set and can bring with it a lot of emotion from family. And so you want it to go well as you're having that goals of care discussion. And so when I was first doing this in my career as a palliative care specialist, and also sometimes when I'm working with a new person, it kind of feels like this. You can watch it being done many, many times over. You can read about it. You can even do role-playing exercises about it. But when it comes to actually having to lead the discussion with a big family meeting, when everyone's looking at you, it can kind of feel like this. So what I hope to offer today is some insight into how we can make it a little more like this. So thank you guys for joining today. I have a short presentation on my thoughts on the subject, and then I'd really like to hear from those who've been going through this most recently. So in any adult learning situation, I think it's always best to do a self-assessment and have a discussion with the person you're teaching on how do they learn best. Do they learn best by reading about it, watching a video, doing a role-playing exercise? It's really helpful for you as a learner to know that. And then have them do their homework. And this is reading the chart, having a really good understanding of the clinical picture, speaking to all the specialists and the attending involved, speaking to the nurses, having their ducks in a row and knowing what's going on can really help ease any anxiety when walking into that room. Have them practice the elevator speech. Ideally, the big come to Jesus family meeting wouldn't be the time that you're introducing yourself in palliative care for the first time, but perhaps it is. And perhaps there are people in the room who have not met that palliative care specialist before. So usually there's questions about what is palliative care? Why are we here? And I find that if that doesn't go well, that explanation of palliative care, it can make the person leading the meeting have maybe some anxiety. It doesn't start things off on a good foot. So it's always best to practice the elevator speech and to have that down. I like to discuss the clinical picture with the person leading the meeting beforehand. Make sure that we're both on the same page ourselves on what the big issues are, what's going on with the patient, what are the treatment options available. So when you're presenting that to someone or the family or the patient, whatever it may be, that we're not missing anything. So talk about that before you walk in the room as a learner and a teacher. And then I think it's good to identify, what does the learner struggle with the most? Is it understanding the clinical picture? Is it speaking with the attending or the intensivist? Is it responding to the emotion in the room? Identify that up front and maybe work through some of the resources that are available, and we'll talk about resources in a bit, to deal with that up front. And this is just good palliative care advice in general. Have a plan, but not an agenda. So go in, what are we trying to accomplish in this goals of care meeting today as palliative care specialists, but also with the team. But also give that new person permission to understand that if we don't get to all the things, it's okay. Yes, we would really love to bring up code status, but if the family is far too overwhelmed by all the other discussions that are being had, it's absolutely okay to not push, because that might break the therapeutic relationship. So we go in with a plan, but not an agenda. And this might, some people might disagree with this, but I kind of always like to have an out, whether that is a hand signal, a word, a look, or even just the ability and the permission to say, what do you think, Patrice? As a way of saying, I don't know what I'm doing, please help me. I think it's a good idea to have that discussion beforehand. Let me know when you need me to jump in. So some of the resources that are available, these are just a few, but the ones that I use most often in orientation is communication skills training. It's a CAPC module. So if you have access to CAPC modules, which if you're part of Advocate Aurora, you do, which is a series of online modules. Vital Talk, which is a series of videos. And this is what I mean when I say, well, how does the person learn best? Maybe online modules will do nothing for them, but watching people lead family meetings and videos would really be helpful. And then Fast Facts number 222 through 227 breaks down pieces of the family meeting, which is part of the orientation process here for the APCs at Aurora. But I think it's good to point out exactly what resources that you have. And there's an app, so you can read them on the way to your family meeting. One final thought before we open it up for discussion is, when I was learning this skill set, what was really helpful for me was having a framework, because if you get in trouble, if you're not sure what to do next, you can go back to these frameworks, and there's a lot of them out there. I have a few here, and they're all pretty much the same thing. But I'm sure you're familiar with the Spikes protocol. I found another one that I had not heard before this presentation called REMAP, or the Ask, Tell, Ask. So I'll just kind of focus on the Spikes protocol, which is the same as all the others. Setting the setting. So can everyone see each other, hear each other? Does everyone have a chair? Are you in a quieter room without people walking by? Things like that. Asking the patient or family, what have they heard? What do they understand? What's their perception of what's going on? So that helps you get an understanding of where they're at, where you're starting from. And then asking permission to share what you know, sharing that knowledge, responding to the emotion, providing empathy, working through the discussion of what to do next, and then summarizing and strategizing the next steps. Remap is pretty much just another way of saying that. And then a really good one, because if you're under stress, this is easy to remember: ask, tell, ask. So asking what their perception is, asking for permission, telling them what you know, and then asking what their reactions to that is. And repeat until we get to the end. So those are my thoughts on how to go about this. So I would like to open up first to Alicia, who has been through this process in the last few months. She came to us from a primary care setting, and I'd like to hear from her what she found helpful when she was starting out. And then I'd like to open up to the rest of you all to say what's been helpful for you.
The switch from primary care was hard. I was there for 5 years. I was cozy. I knew my first, second, and third line antihypertensives. I knew what vaccines my 12-month-old well child was going to get that afternoon, right? And then I came here and they're talking about morphine for cancer pain and having true life and death conversations. And I was overwhelmed to be a novice again. I didn't know how to calculate morphine equivalents. I never had a code status discussion in the primary care setting. Whether or not that was right, I didn't. But to get comfortable, I had to recognize I did have some goals of care conversation. 16 to 19 a day, 5 days a week, right? They might have looked a little different. Mr. Johnson, your A1C is 9 today. We got to get you below 7. I heard you set the limit that you never wanted insulin because you don't want to poke yourself. What about trying metformin? Hey, Tina, Benny has been dealing with constipation for 2 years. About the 5 cups of whole milk he drinks a day. Let's bump it back to 2% and start a fiber gummy. So although my goals of care conversations weren't as lofty or weighty, I had at least 100 a week for 5 years under my belt. So reassuring myself that I had the building blocks was so helpful for me in the beginning. That there was a lot of things I didn't know how to do, but having goals of care conversations was something I'd been doing even if I wasn't aware of it.
Good morning. I'm Dorothy Wilson. I'm a nurse practitioner with the palliative team here in Kenosha. And I am definitely excited about sharing some of my professional insights regarding palliative care and how we really can help our patients make the best decisions. One of the first things that I think I had to realize was my own biases, my own thought processes concerning end of life and goals of care. And what does that actually mean? Because it means something different for everybody. So once I checked my own biases, which unbeknownst to me, I didn't realize how uncomfortable I was about having conversations surrounding end of life. And I think it's something that we do robotically as clinicians, but we really don't think about it from a personal perspective. And so for me, it put me in a position where I really had to start having some difficult conversations with my own family members about what my wishes would be. And I feel that that was the only way I could do diligence to my patients, is to really go in with a different thought process about how I felt. Which meant I had to tell my adult children that they were not my power of attorney for healthcare. And neither would a spouse or a significant other if I felt like they couldn't honor my wishes. So that's a pretty hot button topic. It was at that time in my house because kids automatically think they should be the people making the decisions. But it really helped me understand family dynamics and being able to help patients navigate through those difficult conversations, because patients typically choose what is in the best interest of the family versus what is in the best interest of themselves. So I'm just excited to be in a different space to be able to offer honest insight, because I challenged myself prior to taking this position. I did not have a power of attorney for healthcare, but I felt it was kind of not fair to have the discussion and not have my own paperwork in order. So now I do. I've had the difficult conversation, but the other piece that I found a little challenging was when we're consulted prematurely and there are still pending tests and results, it's really hard to help patients and families come to some sort of plan. How can you come to an agreement on a plan if you don't really know what's going on? So what I do now is, if I think there's something pending, I kind of talk to the team members, the specialists, and ask, when you say goals of care, what does that actually mean? In the context of what? What is it that you want palliative to do here? And we've come a long ways with just that consult order being put in, and the reason being goals of care. Now I get metastatic cancer, end-stage renal disease. They're very specific, which I think we've come a long ways in 5 months. And now the nurses have gotten in a place where When I ask, okay, you consulted palliative in the context of what, they're actually able to answer that question, because that means that if the staff can answer it, then they can also assist when families have questions as well. So palliative is not necessarily a death sentence. Typically when we show up, people, it's all gloom and doom, but I try to explain that we are an extra layer of support, that we are not there to promote hospice. We're there really for comfort and understanding, and to tie in and summarize the care. And I think doing it that way kind of opens up a door for us to be able to really have relationships and good conversations. So I would say the long and short of it all, if you're new to palliative, one, check your biases. Two, make sure you do a thorough chart review before you go to the bedside, because then you can at least be able to answer questions and speak intelligently about the topic. What I found most challenging is just the hematology oncology piece. I am not on any planet that they are on and able to understand oncology and hematological disorders. And so I thoroughly read their notes and look at their plans, because our oncology patients seem to be a different population. When we're talking to them, it's as if they're hearing this diagnosis for the first time, and they've already gone through 3 rounds of chemo. So what I'm finding is that our oncology populations don't have goals of care conversations on file, and they don't have advanced care planning documents on file. That's a little challenging, because we're already consulted in the thick of a disease that is already metastatic typically. And if a patient has metastasis, I feel like that due diligence and that initial conversation should not be from the palliative team. It really should come from the specialist. So I would say that sometimes that's a bigger challenge. But what I've done to alleviate that is start going directly to the oncologist, the treating team, and say, hey, what does the patient understand in the way of prognosis as it relates to time? Because they always ask us, how much time did they say? Well, if they didn't tell you, they most certainly didn't tell us. So I would say, really get to know your treatment teams, your specialists, establish a bond and a relationship with them, because those conversations will be ongoing and very helpful when you actually get to the bedside and start having those conversations with patients. Because if you understand the treatment recommendations from the specialist, you can help the patient better understand. But for me, I think it's been a very rewarding career, and a nice switch and change of pace to be able to take the time with families and offer that additional support in answering questions. In the way of ordering consults, I would say talk it through with the staff. That has been very helpful here, helping them understand when a consult is appropriate and when it's not. Because I'm finding that they'll say, oh, the patient has social issues. Okay, that is not a reason to consult palliative. You know, if it's a social concern and goals of care are already clear in the way of what they want, and it's just discharge disposition, that requires social work, not necessarily a palliative consult. So I think that what I'm finding is when they don't know what else to do, palliative is the last resort. It's like you go in, talk to the family, maybe you could force them into an agreement to do something. And that really is a poor utilization of the palliative services. So a lot of education surrounding when to consult. But what I've done, like I said, is start talking them through the reasons why. And if it looks like somebody else needs to be consulted, then we find out, we take a different route versus us completing an entire consult note, knowing that we're only there to help with discharge disposition. So the oncology team was routinely consulting palliative just for hospice. And you don't need to consult us if the goals of care are clear. If they've already determined that they want hospice support and services, you guys can put those orders in. You do not need palliative just to put orders in for hospice. But that was the traditional way things were done here. And now things have shifted and changed with a little education. So I would say overall, it does take a little assertiveness. I don't think this is a shy profession by any means, a shy specialty by any means. You need to have a little backbone to be able to support your patients. You know, if you're weak, you get ran over. So people will bulldoze you and force you into things that you don't want to do, or even discussions that you don't want to do. If I find that it's a large family that I'm having the initial goals of care conversation with, along with several different specialists at the same time, I like to do a debrief at the end of the meeting, just so that we can summarize all of our facts, all of our findings, answer any questions that the families may have, but also do a debrief with your team. I'm finding that when we do that, we are all on the same page and we leave the discussion knowing what the patient wanted. Also concerning ethics, we've had a couple of ethics cases where patients have had long length of stay in the ICU and we've exhausted measures, and there's a concern about, you know, the what to do next. I think if you've never really been involved in an ethics case, it can be a little intimidating, because automatically it feels like somebody did something wrong. And I think the best advice that I can offer is just know that ethics is there to really support all parties, not just the patients, but providers too, because we don't always have the answers and we don't always know if we're doing what's best. So I look at it as this is an extra layer of support and a measure to ensure that the patient is at the center of the care planning process, that we're really truly doing what is best for them, but not going into futile things that aren't really going to improve or prolong quality of life. So I think that palliative support is a great service. I wish more providers consulted us earlier rather than later. Get us on board so that we can start those conversations early and build those relationships, so that when things do start to go downhill, we've already set the tone and we can be there as a support, versus coming in when the patient is actively dying. They really don't get a lot of benefits from us when that happens. But thank you so much for inviting me and allow me to be able to just leave a little nugget of knowledge as it relates to how I see things here in the palliative world. So that's all that I have. Happy Friday.
All right. So, hi, I'm Andrei Chernisov. I am a newly minted palliative care doctor, just graduated from Aurora's Hospice and Palliative Fellowship less than a month ago. I wanted to thank Patrice and Martin for allowing me to kind of speak to everyone that's listening today. So regarding the challenges that I think that learners, myself included, face in participating in and guiding goals of care discussions, I think for me, what it all kind of boils down to is one word really, which is confidence. And what I mean by confidence is it's kind of twofold. It's the patients and families' kind of confidence in us, in knowing that we have both, you know, the expertise and the sincerity that we are doing what's best for them in guiding these discussions. But in order to achieve that, I think that the bigger thing is to have confidence in ourselves. And this is honestly kind of the biggest stumble that I've had during my fellowship. And it's really hard to describe. I went into fellowship right after residency. By PGY3, I was very confident in my abilities as a resident. You know, running the inpatient service, not having to precept at clinic. I thought, you know, hey, this medicine stuff, it's not really that bad. But jumping into fellowship, that kind of all got turned on its head. And I think that's particularly because palliative care as a specialty, it kind of forced me to deal with these really complicated issues and make these like, it was just, everything is just so much more complex and intricate in what we have to do. And it just kind of tore my confidence down. I would very often just, have to just think for a long time about what is going on here. What can I do? And I think that, well, I know that patients and families kind of picked up on that. And, when you're not confident in yourself, then it's kind of hard for people that you're trying to help to be confident in, you, as tough as that is. And I wish I had some sort of magic trick to, say like this helped my confidence. I know that going through the fellowship definitely helped, but it's something that I had to actively work on, and it's something that I have to continue working on. And it's part of it is that you're dealing with a medical condition, a medical prognosis, this whole purely academic, like medical aspect of things. But your job in palliative care, and our job in general, is to translate that medical prognosis into what it means, what it actually means for the patient and the family. And trying to figure out what a family and patient's goals, what their values are within the framework of that prognosis. And that's something that you can't really prepare for, no matter what you were doing before palliative care, what your training was, how long you've been doing it. It's something that it's very hard to prepare for this kind of thing, in my opinion. And it just takes time. And that's really the thing that I've learned. I still have a long way to go, but just overall, it's something that I think, the takeaway is that, you have to be confident in yourself. You train for this, you are a medical provider, but having that confidence also requires you to be cognizant of the fact that you have to kind of actively work on it all the time. And it kind of has to be in your head, I can do this, pump yourself up, rehearse, get that kind of feeling for, how things are going and how you should guide the conversations. And, it's only been a year for me, and I feel a little bit better about everything, but I think it's something that, that's just what we have to work on all the time as learners, just building that confidence, because, if we want our patients and families to be confident in our abilities and our, compassion, then we have to show them that, we kind of are confident in our own abilities. And that's the biggest point for me. Thank you.
I think that's really profound and not something I'd really thought of before. We had this discussion and planning for this is what kind of experiences can we bring forward to help ease the pain of learning this skill, I guess. So I know that there's a couple people on here who have more recently been through fellowship, and we've all been here at one point. So I'd really like to hear other people's thoughts on what helped them.
So if I could share, this is Maureen. I'm gonna put us on video, ladies. Okay, so if what really helped was being in a goals of care meeting with somebody else early on and getting feedback immediately from somebody else, Martin or Katrina or Lindsay, depending on who I was with, having them give feedback kind of in the immediate so that I could, recognize what I did or didn't do, opportunities for doing something differently, and then, changing the way I did something the next time. So that was super helpful. And then also just sitting in meetings with the experts, right? The people who had been here a longer time and having them model what it looks like. So part of that for me was also learning the language, learning the dialogue that is, there's a palliative speak, right? So there's sort of a script, but there isn't, but there's sort of a script that we use that it's important to try and nail down pieces of it so that I have, things in my tool belt to pull from. And I think that was helpful to watch other people do it over and over again. So, and have it be modeled. That was important, and that worked for me.
Oh, can I say something?
Yes, please, Rose.
I think as a companion to kind of what Maureen was saying, also to observe other providers who are not palliative care and how those discussions go, I think is helpful. Like there's the know what not to do, or when you see, other providers do a good job and maybe it's not the palliative speak, but it's a different way of communicating with people. So I think listening to those other providers that are within your family meetings can really help as well.
Right. I agree. And some of that I learned from watching the critical care attendings, because a lot of times they have to give those immediate conversations as transitions happen very, very quickly in the ICU. And so when you listen to the three options, we can stay the course, we can pull back, or we can go this direction. It's pretty pretty cut and dry when they're doing it in the acute setting like that. So
one of the big things that I took away was, and that's why I commented that I really like the having a plan, not an agenda. But it was a little difficult early in my fellowship to, when the team would call with a consult saying, we need code status change, that directive, to just recognize that is an agenda, and you can't have that because that may not actually be what the patient and their family want. So coming to that conclusion that I did need to check the agenda at the door and really get to what the patient and their family or their decision makers really were looking for. And I think that's a huge adjustment from being a treating clinician. And I think that's where often our colleagues that are not in palliative do get stuck, because when you're the treating clinician, I think you always have an agenda, even if you try really hard not to. As a treating clinician, I think it's pretty close to impossible to really, really let go of the agenda. And I think that's where we can provide a lot of value as palliative specialists, is to come in and not have to have an agenda. When you're a treating clinician, there are certain things you can't let go of. You can't let go of your metrics. You can't let go, those are really important in assigning what you do and how you do it. And so I think that is where, when things get sticky, palliative does provide a lot of extra value.
Yeah, I want to piggyback off of that, because I think teaching how to have goals of care conversations as a consultant, it's extra complex because there are wrinkles, exactly, that primary teams may not have. Because one of those wrinkles is that as a consultant, I'm being asked by someone else to see their patient. I don't get to see them unless I'm invited. And so even though I think everyone in healthcare wants to do what's best for their patients, and I truly believe that, sometimes patient and doctor don't see eye to eye on what it means to do what is best. And so I think part of the art form in palliative care is trying to find a balance of advocating for your patient while understanding the culture of the place you work at and advocating for your colleagues as well. So it's the old saying of, is it just doing what's best for my patient, or it's doing what's best for my patient and for my colleagues? Because the far extreme would be, I'm going to do what's best for my patient come hell or high water, no matter what anybody thinks. And we've all seen that and maybe even felt that a little bit, but that burns bridges to the point where we're no longer able to see any patients to provide anything. And so that's a skill that new learners work on, and I think we all work on until the day that we retire, because that can be a challenge.
I'm thinking about the plan, have a plan but not an agenda idea also, and how I think for people coming into palliative care in a consulting role, and even for learners who are going through residency training and trying to figure out their own styles, it sometimes feels like this idea of having a goals of care discussion has blown up into something abnormal and exotic when really I think it works better. It works best when you have some sort of framework or context that you're trying to contextualize this discussion for the patient and family. One of the things I try to do and encourage is for to have a story and try to help figure out the medical story and how the patient got to this point and what are the decisions needed now? How urgent are these decisions? And usually if you are able to somehow frame the medical situation into a story that's understandable to patient or the family, the options that you discuss make a lot more sense and the right decision is more often made. So if I guess one bit of advice I would give to learners is to just try to figure out how to normalize the discussion and figure out what are you trying to decide. Is it more of an advanced care planning discussion, or is it really like an end of life and kind of hospice discussion? I think it takes some experience to understand those nuances, though. So definitely need some repetitions for that.
This is why I wanted to have this discussion, because I think we probably do that without even being able to identify that that's what's happening. Because I, as you were talking and thinking of when I go in a room and kind of explain why I'm there. Sometimes people are very anxious because they think, oh, they're going to come tell me my loved one is dying, and that's not the case at all. So I would just like to talk to you today about X, Y, and Z. Kind of normalizes that discussion. And I didn't think of it in that terms until you said that. So thanks. Anyone feeling brave to tell a story of when things didn't go well in their teaching?
I think as in most meetings that I'm in, I'm the senior person, so I don't mind being brave. As I say more and more frequently all the time, I'm not ashamed to reveal my ignorance. So that's, I guess, my strongest asset. So I don't have a particular one. There's probably hundreds over the years. I've been in hospice and palliative care for about 30 years, but I think the discussion so far, and I want to just say thank you, Patrice and Alicia, for your structure, because my stories almost always is violating what you had down in your slides and what Steve and others have said is that, and I think what Steve said is this is what we're supposed to be good at. So often that translated into we're in charge and you know the agenda setting, and I think it's already been addressed that we go in there and as the experts, which I think is we should have known, or I should have known, that was a flawed strategy, and that's how we're supposed to be different, right? Is from the rest of medicine or healthcare is that it's a more collaborative approach. So I would say, as a very general statement, your counsel on how to do it right is spot on, and my mistakes and failures have been. Yeah, I should have known that years ago. And I like you, the CAPC, the Vital Talk, and the Fast Facts, and all the other resources. If somebody's new, I would use that to complement the guidelines you provided. But that's all I have to say about that, I guess.
Thank you. I think as I was putting this together, I was like, well, what have I not done in the past? What have I failed to do? And I think I probably failed to do all the things that I'm advising people to do at some point. So I own that as well.
I would add another comment. I think you kind of addressed that, and I think that's great. A sub piece of that is myself and the team, sometimes we did not proactively look at what are some elephants in the room that we might be facing. And then when it caught us unaware, then things just went to pieces. So thank you again.
This is a very good talk. And I think that just like we need to know how to approach patients and families and the steps to take, I think it's important, especially as you get more experience, when things are not going well, what do you do? And how do you gracefully and compassionately put the brakes on? And I think that that's a skill set all in itself, that, you know, comes with experience, but of course, you know, there may be some steps to that too, that, you know, might be very useful for people as well.
All right, guys. I think we're just about at time. Thank you, everybody, for all of your input today.
Thank you for the discussion.
Yeah. Have a great weekend, everybody. See you
Thanks,
next
Patrice.
week.